a very warm welcome, everybody. I'm so impressed that you're all here and you're all come from all over the country and Wales and Ireland. It's brilliant. So, as you all know, we're talking about ADHD and substance use today. Our discussion will range from the science, diagnosis, risk factors, substance use, of course. And we will also hear from Alison, a very special guest today. Thank you, Alison, for coming. So without further ado, as they say, I'm going to introduce you to our first speaker, Professor Chris Chandler. He's at London Metropolitan University, and his research interests are the neuropsychological mechanisms underpinning substance use. He has written 2 books, which I have to say is 2 more than I've written, Chris. The Science of ADHD, a guide for parents and professionals. And he's just told us that that's in its 2nd edition. And a second book with Anita Andrews, Addiction, a biopsychosocial perspective. And that is a cracking book, everybody. I've used that for some of my teaching. It's fantastic. So, Chris, you're on.
Well, thank you for that introduction, Joe. I've come to ADHD from a very personal perspective. Many years ago now, my son was diagnosed with ADHD and he was prescribed methylphenidate. And what I found frustrated me, and I come from a kind of biological background, that there was very little evidence that was accessible, and trying to talk to schools was very difficult about this. And also my interest in drug use. So, as Joe said, I wrote a book on the science of ADHD, which includes a chapter on what we're talking about today. So what I want to do really briefly is to take you through some of the main points to look at ADHD and drug use. So ADHD is now classed as a neurodevelopmental disorder. Previously, it was included as a behavioural disorder, but the science has informed the classification of this, so it now becomes a neurodevelopmental disorder that's characterized by 3 symptom clusters of inattention, hyperactivity, and impulsivity. Now, as a neurodevelopmental disorder, it tends to be caught up with children. Most people are thinking that it was a childhood condition and that you might grow out of it. And yeah, that's true, you might grow out of it. But the evidence is much more supportive and now is included in diagnostic criteria of it being an adult condition as well, with many people exhibiting ADHD. But it's not like when you're a child. Childhood behaviours are very different to those of an adult. So it does change somewhat. And the reason that they discovered the adult ADHD was really from clinicians talking to the parents of the children that they were evaluating. And yeah, the common sort of ground was that, is exactly what I was like as a child as well. So it started to become more transparent that this wasn't something that had stopped as they reached the kind of magic age of 18 or whatever, but actually something that continued and had some sort of functional impact. So adult ADHD is a thing, and it becomes much more of a thing for the drug-taking world. And these are the kind of symptoms that, or behaviours, the effects that having adult ADHD has on individuals. And one of the things I always think about when you see these, classifications of conditions can often be really dry and don't really give you a feeling for what it's like to have the condition. And think about this, you look at these and you think, well, I have a lot of this, but yeah, these are extremes. It's having functional impact. Now, when it comes to ADHD, you tend not just to have ADHD. So things like anxiety can be part of it, other affective disorders, conduct disorders, but also substance misuse can be a big part of it. And there's a couple of ways of looking at this. You can either look at groups of people that are presenting because of their drug use, or look at people with ADHD and see what their drug use is like. And when it comes down to looking at the drug using population, this is an old study, but around about 20% of substance abusers had symptoms consistent with ADHD diagnosis. That's outstripping the kind of general population prevalence by about 15% there. And then when you look at people with ADHD, you can see that there was quite a large increase in the likelihood of taking drugs if those people were presenting with ADHD. It also was associated particularly with nicotine, but that in part is due to the access. And there's good reason for looking at ADHD and addiction or substance misuse. So neurobiologically, there's some common ground. The mechanisms within the brain, the changes that we're seeing in the brain, focuses on the dopamine system and the prefrontal cortex. But particularly, we talk about a reward pathway in which drugs are beautifully able to exploit. But also neuropsychologically, there's a big overlap, particularly with things like impulsivity. Now, impulsivity doesn't even get included in the ADHD title. But when you start looking at the origins and trying to explain ADHD, impulsivity gets center stage. Being able to stop yourself doing something is really difficult for people with ADHD. It's actually pretty difficult for people with substance misuse problems. And there is a tendency to want to get the big effect now rather than delay reinforcement, delay getting your rewards. And also theoretical aspects of ADHD and addiction crossover. Again, I won't go into too much, and I'm sure we'll be talking a little bit more about the self-medication. And I noticed, I think it was Kylie who said that she's working with somebody who is using drugs, I think it was ketamine, to self-medicate, but also that this, normal behavioural, normal teaching methods that are deployed tend not to work too well until medication's given because of the idea that the reward pathway is somehow not as active. Now, I wanted to mention a little bit about the treatment here. There are, fortunately, sadly, since the first edition of it, there's a lot more drugs now available. But the mainstays tend to be psychostimulants, which enhance dopamine levels in the brain. Methylphenidate, which is probably better known by its brand name of Ritalin, is used, and amphetamine is used, which might seem really counterintuitive to give things like amphetamine and something like methylphenidate, which is fairly similar to cocaine in many ways. They're the main drugs that are used, but there are now other drugs that are coming along. Atomoxetine is probably the most common one, but many more are coming along. Now, the reason I mention these drugs is because they do get, how should we put it, a bad reputation. And, here's a sort of picture that was, I'm not sure where I got it from, but maybe somewhere like Mumsnet, where they talk about kiddie cocaine, which is something that, it gets people's attention. And it starts to present it as, these are really strong drugs that are going to make your children, you're going to become addicted, etc. And of course, there are certain aspects there that are problematic. But the vast majority of people start off on methylphenidate, Ritalin, or other brand names, because it comes in many different formats. And as I say, the guilt by association is often because it's very similar to cocaine, which people know to be problematic. And it's also a controlled substance. Yeah, my point here is that the drugs that we use to treat ADHD are often considered to be addictive drugs or have certain commonality with addictive drugs. But this, just to sort of draw your attention to something, the way the drugs are delivered reduces the likelihood of later addiction. And indeed, the marketing of the pharmaceutical companies of selling drugs is all about reducing the likelihood of substance use disorders. The drug's the same. They're just trying to deliver it in a way that's going to be less likely to be abused or misused. And this is giving methylphenidate on the left-hand side, either by an injection, where it gets to the brain super quick, or by a tablet, which is the kind of regular way that it's consumed. And what you can see in this is that the very dark, the black dots are taking it intravenously. And people who are taking that, they felt like they were getting high. But if they take the same drug, the same dose, but via a tablet where it kind of it slowly gets to the brain over about a 20-minute period or so, they're not getting that high. So it's less likely to be consumed for reasons of wanting to get a high out of it. You might be doing it for many other reasons. Misuse of it comes from cognitive enhancement, being sidetracked by other people to get the one up to concentrate on the deadline, etc. There are also appetite suppressants. Well, amphetamine is well known for that. So they might get misused for those reasons. But in terms of getting high, like I say, there are definitely better ways of doing that. There is one of the aspects about having these drugs that are put into a formula that mean they get to the brain slowly and then they last for much longer, so you don't need to keep taking them, is that they might be useful for treating psychostimulant addiction, like methadone is used for heroin. It has been looked at, it has been deployed. It's not been great. Other drugs coming along, like amphetamine, might be a little bit better, modafinil a little bit better. The other question that people have is, does taking methadone protect you from being treated with later addiction? Is it going to protect you? Well, there's variables there. Early treatment and longer duration tends to reduce the risk. Well, that's what it's been found to. But others have found little effect. And there's many variables that are involved. Like, when do you start taking it, particularly during adolescence when a lot of people's drug taking really kicks in? That's a strong period of neural organization. So there are reasons why it may well be protected. It might be protected, not just because of neurobiological reasons, but because actually people are able to engage in work or education in a way that stops them getting caught up in those environments. And from a theoretical perspective, I've already mentioned that there is a reduced efficacy of reward pathways. That, you're just not getting the same level of activity in there. So rewards aren't as strong. Drugs come in and they exploit that. Or you might self-medicate, and I think we'll be hearing a little bit about that later on, where they're used to calm down, feel relaxed, feel chilled out, be able to concentrate less. And the classic example is people who've taken cocaine. They don't get the cocaine high; they just feel quite calm. But that's anecdotal evidence, and obviously one wouldn't be saying that would be a good way of managing it. Perhaps the most common way of managing in self-medication is nicotine and smoking. What's happening now is a move away from psychostimulants, which will have less effect. And there are more and more of these coming on the market, and hopefully these will eventually be evaluated further for substance misuse. But at the moment, they themselves aren't considered to be the kiddie cocaine equivalents, but whether they're going to be useful in managing our substance misuse side still remains to be determined. So, in summary, there are neurobiological reasons to combine the two. There are neuropsychological reasons. The evidence in the literature supports a big connection, and the drugs that are used are, when you look online, they're extremely worrying for people that they're taking heavy-duty medication that would also be addictive. But the likelihood of that is somewhat different to the media presentation of it. And I think I've probably spoken far too long, so I'll just say thank you and let the next person go ahead.
Thank you, Chris. What a fantastic overview. So, all panelists, I have some really nice questions, and I think everybody should feel free to answer these. But a favourite question from me as a psychedelic therapy worker, I suppose, what are your thoughts on the effectiveness of microdosing with LSD? And that's $1 million question.
I think the jury's still out on microdosing, isn't it? As a view, my sort of, there's very little evidence out there with regard to ADHD and microdosing, and it's not looking like a great route. And there's quite a few people that regard it as more of a placebo effect anyway. Although people with ADHD aren't necessarily great placebo respondents.
Oh, that's interesting. Okay, so we did have a microdosing webinar, didn't we? And I'm just thinking about trials. I can't think of any trials. There haven't been a lot of microdosing trials, actually. Anneka or Joe, any thoughts? Or Alison?
I agree with Chris, actually, in that, from a trial point of view, there isn't much evidence to say there is effectiveness. I think there was one trial that looked at emotion regulation in ADHD, and that everybody was interested, but actually didn't show any positive effects. So I think jury is definitely still out there, but at the moment there isn't any evidence to support the use in ADHD, particularly adults.
Really, really interesting. I'm really glad you brought that up, Anne. That's a great question. So does clonidine monotherapy as a noradrenergic as opposed to a dopaminergic drug, does that work?
Clonidine has been used, guanfacine. A lot of the new drugs are noradrenergic or mixed.
Yeah.
And I guess because amphetamine was working and methylphenidate was working early on, all the money followed that. But it's a lot of the discussions about the origins, the neurobiological origins, were focused on dopamine systems because of those drugs leading that life. But actually, it's looking like it's a mix of noradrenergic and certainly noradrenergic in prefrontal cortex.
Yeah, and I think from a recent network meta-analysis, clonidine actually didn't show great data, guanfacine more so than clonidine. There is, though, an absence of evidence in adults. So a lot of these trials, a lot of the work that we look at are often in children, adolescents, where there's a bit more data. But actually trials in adults, clonidine not quite as good as guanfacine, actually.
I think the side effects with clonidine are a bit problematic, aren't they?
Yeah, I don't know, Joe, if you wanted.
Yeah, I have inherited a few patients, children who were on clonidine for many years, and there's a minority where it has continued to work. But, I've seen non-stimulants like clonidine used more as an add-on sometimes with stimulants. So there are some patients who may have struggled to tolerate higher doses of stimulants, and they may have been on a smaller dose of a non-stimulant as well. But just as monotherapy, fewer have had just that good response in adults. Guanfacine is only, it's not licensed in adults, it's off-license prescribing in adults. And again, in my experience, it's had better results as an adjunctive treatment, as an add-on, especially if people have struggled to tolerate higher doses of the stimulant. So their ADHD is treated, but partially treated, and then the non-stimulant kind of gives them a bit more balance. And I've had a lot of adult patients reporting some improvement with emotional dysregulation symptom with the guanfacine, and emotional dysregulation is one of the most common associated symptom of ADHD, the frequent highs and lows in mood. And so there is a place, but bit debated how much of a place there is as monotherapy.
Really interesting, really good to know. I have a question from John. He's interested on the impact of stigma for these two very highly stigmatized conditions. Is that a big barrier for people to get support?
Gosh, yeah, I think both ADHD and definitely substance use. I'd say more so substance use at the moment. And I think events like this are just absolutely wonderful because, as we know, educating people to understand the risks that are associated with conditions like ADHD, substance use disorder, but also the impact that treatment can have for people. But yeah, I've had many patients that have faced so many stigmatizing, even clinicians, services, jobs, in every realm of life.
It's terrible, isn't it?
Yeah, fully agree with Anneka's view. And we see so many patients who may have been on treatment all through their childhood. And as soon as they get to that age where they can make that decision themselves, whether they have to stay on it or not, they may decide, no, I don't want it. I've had patients who have said things like, it is so embarrassing in school when my friends would say, have you taken your tablets? Or even teachers would say, have you taken your tablets? And, so the earliest opportunity they had to stop meds, to just be normal without having to take a chemical to be normal, and they may gravitate towards cannabis or other drugs as a way of self-medicating, as we keep hearing. And we've had so many referrals of young people who were in treatment for many years, so pretty much almost throughout their childhood, have had a long gap and then come back to adult services. It could be somebody open to children's services 6 to 16, big gap, they get referred in their late 20s or early 30s. And that's a very common occurrence.
And there are quite a lot of questions about cannabis use in people with ADHD.
Very common. Very, very, very common. I would say it's probably the second most common that I see. And actually, the literature, the research would show that as well in adults with ADHD. And I might touch on this a little bit later as well. But one thing I always ask with anybody using any substance is not, of course, I always ask how often are you using, how much are you using? But in ADHD, I always ask why? Why are you using it? And one of the most common things I hear with cannabis is that people do try and use it to relax. I have lots of patients that I've seen that will use it later on at night, so 10 o'clock at night, to just help them sleep.
Yeah.
Of course, we can't recommend this, and I would always advocate that treating the ADHD should ultimately help with that, and then hopefully reduce that sort of reliance on using cannabis for that self-medicating aspect.
And actually, I see somebody's put in the chat that the Drug Science Project 2021, people have received prescriptions for ADHD of medical cannabis. It's interesting.
Really interesting.
Yeah, we get asked this quite a lot. Can we prescribe medical cannabis? And obviously something we find very difficult in an NHS clinic.
Well, it's not been available on the NHS,
No,
is it?
no.
That's been a disaster as well. Project 2021's 5,000 patients so far for various disorders, medical cannabis, really. It's a very rich real-world trial data set. It's fantastic. Lots of publications. Okay, well, I'm digressing. So, folks, don't panic. I can see there are loads of questions, but I think we'll get on with our next talk. So we'll go to Anneka, and Anneka's a clinical academic psychiatry fellow. She's working at the University of Oxford. She has a very, as you've heard, a very keen interest and a lot of knowledge about adult ADHD. She practices psychiatry in Thames Valley and is a very, very active researcher. And I have known Anneka for some time. She was a PhD student of mine, so it's a particular privilege for me to have Anneka on this webinar. So she's working on targeted individualized treatment in mental health, particularly ADHD and mood disorders in women. She's working on the side effect profiles of ADHD medication and identifying treatment predictors in people with ADHD. So Anneka, very warm welcome to Street Drugs Discussions.
Thanks, Jo. Thanks so much for that introduction. I've almost blushed. It's really, really great to be here. And I think, as I said, it's such an important topic to be discussing. And I'm going to be talking about diagnosis, risk factors, substance use in general, and the association with ADHD. It's quite a lot to cover in 10-15 minutes. So yeah, wish me luck. So yes, this is me. So I won't dwell on lots of these points, but I think overall revisiting ADHD to see what we actually mean. And Chris, thank you so much. Neurodevelopmental condition, absolutely. A mental health condition, I often put this on because I'm met with patients that say, oh, we can't call it a mental health condition. And I say, actually, we need to embrace it to call it a mental health condition, which it is recognised as, for us to be able to move forward to increase awareness of ADHD across the globe, really, particularly in adults, particularly in women. Thanks, Chris, again. So issues with paying attention, focusing, impulsivity, hyperactivity as well. One of my interests is women with ADHD and the influence of hormones in ADHD. Not only ADHD, the sort of symptomatology, how it presents to us, but actually how it can differ in terms of treatment and that sort of research that I want to be taking forward as I move on. We know that there's a huge genetic component and that environmental factors also play a role in this. I'll talk a little bit more about this. And I guess one of the reasons that I love working with patients with ADHD is that it's so variable. I never see a single patient that is the same or in any way, shape or form to another patient. And actually, this is one of the criticisms of some of our diagnostic criteria is, are we actually capturing what we see in adults? And finally, I've said it's a terrible name. It's a terrible name because it doesn't have impulsivity, so one of the core symptoms. So we mentioned attention and hyperactivity, but we don't mention impulsivity. And secondly, that we have two negatives in there. So we have the word deficit and disorder. There's a big move now to try and move away from this sort of negative terminology to, again, help with that stigma that we talked about. And so calling it a condition, we've done this in autism, so autism spectrum condition now, as it's known, rather than disorder. And hopefully we'll move towards that in ADHD. Chris very kindly covered the core symptoms of ADHD, but I'm also going to throw into the mix here is what I've called in my orange bubble the psychological symptoms of ADHD. And these are what we see every day in our clinic. And also there's a lot of research looking at this. And these are things like, so we particularly see low mood in people with ADHD, not necessarily depression, although we do see depression, but real low mood. We see mood instability, and we see emotional dysregulation. So that inability to regulate emotions, being up and down continuously. And these actually can be more impairing than some of the core symptoms in ADHD. So whilst they're not recognized in what we call our diagnostic criteria, they are absolutely imperative to something we should be looking towards treating, because these are the things that actually do impair our patients. I'm always asked, how do you diagnose ADHD? How, in an assessment, how does it work? What are you looking for? What are you doing? And there are certain things in psychiatry. We love a tick box. We do. We love to tick boxes. And we need to tick a number of boxes to say that there are enough symptoms of inattention, hyperactivity, impulsivity. But importantly, what we need to show is that these are not confined to one area of life. So it's not that actually in work, that you're really bored in work meetings, but actually you come home and everything at home's fine. There's no issues in being bored doing tasks at home. There's no forgetfulness at home. A relationship, no problems in relationship. I'd probably say then there's something wrong in work. In ADHD, we need to see that it's pervasive. It goes across these different domains. So actually going home, listening to your spouse, you also might find boring at times as well, and might find it difficult to engage in those conversations when they come home and talk to you about work. This is something I hear often. This is pervasive, going across different realms of life, and this is what we need to show when we're doing our assessments. As we said earlier as well, symptoms of ADHD not only have to be there, so we know lots of people are forgetful, we know lots of people get bored in certain things, we know lots of people are disorganized. And whilst these are common symptoms of ADHD, we need to show that they impair in functioning. So that actually that forgetfulness has caused missed hospital appointments, which has caused mistreatment, that poor organisation has resulted in a loss of job or multiple jobs. So we need to see that impairment in functioning. We also, and again, I'm quite biased as to who should be doing assessments, and this is one of my reasons as to why I think trained mental health professionals should be doing it, is that we need to show that these symptoms are not better explained by another mental health condition, not due to a personality disorder, or not due to a mood disorder, bipolar disorder, for example. We need to show that this actually is ADHD. And I think it's sort of one of the hardest things at times can be actually showing, which is another one of the criteria, that these symptoms are present before the age of 12. Now, I don't know where that age 12's come from. It used to be age 7, it used to be age 6. We've now moved to age 12. We need to show that these symptoms are present before age 12. Now, if I've got somebody sat in front of me in clinic who's 70 years old, coming for an assessment of ADHD, it can be very difficult to say, so when you were in primary school, do you remember? And they'll say no. And I'll say, can I talk to any parents? No, parents are dead. What about friends? Well, a couple of those got Alzheimer's now. So, you might not get the best history. And actually, the recognition of ADHD that some 20, 30 years ago actually is not as well advanced as we are now. So actually, this can be quite difficult. This is why I do the work, I think, is because it's just so important as a condition, adult ADHD. And I think in the UK, we should be ashamed of ourselves in some ways, because whilst we know that there's a global prevalence of around 3 to 5% of people having ADHD, in the UK, we estimate we're probably only treating around about 10 to 20% of people. This is shocking. We know this number is increasing. And we know it's increasing because we think it's because of increased recognition of ADHD, the stigma being reduced as well. So more and more people are actually coming for assessments. And as Chris said earlier, we know now that ADHD is not just confined to childhood. It's not just a childhood disorder, and actually can persist in up to about 70% of people in adulthood. Now, I had to bring in, just want to show you here at the top. So the 3-to-1 ratio, 3 boys to every girl that's diagnosed with ADHD. Now, this is really interesting, and it's interesting for me treating adults because actually we see these numbers level out in adulthood, that there's 1.16 males to every 1 female diagnosed with ADHD. And I think this is really interesting and highlights the importance that this is not just a condition of men, of young boys, as typically thought. Actually, this really, really affects women too. So moving on to talk about risk factors, the best way to think about this is in 2 ways. We have environmental risk factors and we have genetic ones. And when we're doing an assessment, we'll often ask some things that I think sometimes patients think, that's a bit weird that you're asking me that. So we'll often ask about pregnancy. So were you born on time? Did mum smoke during pregnancy? Did mum drink during pregnancy? Did mum have postnatal depression? All these things. And we're asking these because these are known risk factors for developing ADHD. Now, risk factors do not necessarily mean causation. So if you have one of these risk factors, you are not guaranteed to have ADHD. It's accumulation of these risk factors in combination with what we think some genetic factors as well. Just to go over a couple more. So abuse, I'm often asked about this in terms of trauma. So yep, physical abuse or neglect as a young child is a known risk factor for developing adult ADHD, and also lower socioeconomic status. Now, I think what's important as well is lots of these actually are risk factors for other mental health conditions, depression, anxiety, for example. I think maternal obesity is an interesting one because, and I just highlight this because actually people with ADHD are almost 50% chance of increased risk of having obesity themselves. There's a brilliant meta-analysis sort of showing these data. Now, I wish we could identify the one gene, the ADHD gene, but we can't. We haven't been able to do that yet. There is no one ADHD gene. There are lots and lots of trials in twin studies, family studies, adoption studies, where we look at how heritable, so how likely ADHD is to appear in these families. And actually, we think that genetic factors account for about 75% of ADHD. So a huge genetic component, huge. So that's why we do see it run in families. And that's why in an assessment, I'll often ask, is there any ADHD in your family? And what we think, and again, we need lots more research to show this, is that it's a combination of these genetic variants coming together, having a small effect, but increasing that risk. Throw in some of those environmental factors that we talked about, interacting in the right way with these genes, and we increase the risk of ADHD. I'm just going to really briefly mention the management of ADHD. And I think that my main purpose of this slide really is to say that whilst today we're focusing a lot on medication, to just be mindful that we do try and take a holistic approach to managing ADHD. The reason that we focus mainly on medication is because the effect size of medication working for those with ADHD is really high, which is great for us in psychiatry because actually lots of our medications don't have that high effect size. But there are roles for absolutely psychological, social therapies as well, not just that biological one. Somebody in the chat earlier asked a question about what happens if we don't treat ADHD. Well, I will tell you. Lots and lots of adverse outcomes is the honest answer. And there's lots of really cool studies actually looking at lots of these different things. We know that people with untreated ADHD are more likely to have relationship problems, higher rates of divorce, multiple relationships. We know women in particular actually at increased risk of STIs, more likely to have multiple pregnancies, more likely to have unwanted pregnancies, all risks from ADHD. Criminal behavior, we know people are more likely to offend if they've got ADHD, more likely to offend in violent crimes if they've got ADHD. Motor accidents, People with ADHD are less likely to complete university, are less likely to enter university. Increasing risk-taking behaviours I mentioned before about STIs. But the two I'm really going to focus in on here are the mental health consequences and, of course, substance misuse. So we know that actually having ADHD increases your risk of having another mental health condition. Most commonly depression. I know Chris talked about this earlier as well, depression and anxiety. And this is, again, really important for us, because when we're treating ADHD, we need to have this in mind, that we need to be looking at these conditions. But the reason we're all here today is to talk about substance abuse. And you can see actually substance abuse at this cross-sectional data level is about 9 to 10%. Alcohol use in particular, and I see this all the time, men, women of all age. But let's just zoom in a little bit on substance abuse. And actually, and I think this figure it's shocking, but I think really, really important, is that the lifetime risk for somebody to have substance use disorder in ADHD is 52% compared to 27% that somebody without ADHD would have, which is pretty high actually. But particularly for ADHD, this is doubled. This is really, really high. And again, we need to really be thinking about identifying this. We also see, though, if we took people that are actually seeking help for substance abuse, and if we did an ADHD assessment on them, actually about 10 to 25% of them would meet the criteria for having ADHD. So it goes both ways, like Chris was saying earlier as well. And this is, again, compared to sort of 3.5% of the general population. So huge increases in numbers. So we're often thought, why is this? Why are our adults with ADHD resorting to substances? And there are lots and lots of theories around there, that self-medication that we talked about, and I'm sure we'll have more questions around that. But impulsivity, and this is where the strongest data are actually from clinical trials, and that usually people with ADHD start using substances a little bit earlier than people without ADHD. Lots of people with ADHD try and fit into certain crowds, may get in with the wrong crowd, which may then lead to start using substances. But that taking a substance without thinking about it, that impulsivity element, absolutely. And again, are the shared risk factors, and we absolutely think there are in terms of substance abuse and ADHD. Mood, having low mood actually is a really interesting one, and that sort of self-medication in that as well. In general, we need lots more clinical trials on this, and because they really vary, because actually they include all different substances, cocaine, cannabis, alcohol, amphetamines, you name it, will be included. So it's really variable, the clinical trials we have. But what we look at is actually if we treat ADHD with pharmacological interventions, medication, what happens? Do we improve ADHD, and do we improve the substance use? And the two references I've got on the screen here from meta-analyses where we've combined all those clinical trials. And what we see quite robustly actually across lots of trials is that we see that treating ADHD with ADHD medication in substance use improves the symptoms of ADHD. Some trials show that it's minimally effective in reducing substance use, whereas some trials actually show there's a moderate effect in actually reducing both the ADHD symptoms and the symptoms of substance use. So those cravings, the actual amount of substance use, abstinence from substance use. There are quite a lot of trials that do show there are improvements, but it is conflicting. We need more and more of these trials. And again, if we improve the stigma, hopefully we can improve recruitment into these trials as well. There's some really good clinical trials that show for people with a history of substance use or active substance use, actually, one of the reasons why we might not see improvements in those substance use symptoms could be that we're not using high enough doses. And actually going off license into higher doses of particularly stimulant medication, that we actually then start to see the improvements in ADHD symptoms of substance use. And again, we think that by treating the ADHD, we might reduce that impulsivity element. We may improve that self-medication element that then stops people making those impulsive choices to self-medicate for their substance use. Bit of a summary. So ADHD, common condition in adults. We know it's not just one gene, there's lots of variants in genes that come together, but with environmental factors. Huge lifetime risk of substance abuse in adults, 52% compared to 27%. Treating ADHD is crucial. We absolutely need to be doing this. And, why I'm here today is raising that awareness as well and understanding for everyone.
Fantastic. That's great. Thank you so much, Anneka. Oh, there's a lot to take in there, actually. But in the context of some of the things you've been discussing, Vinny is asking, is there any genetic screening or a sort of biomarker screens?
That's a really, really good question. And I'm often asked this, particularly in any private work that I do. I'm often asked, can I go and get a genetic screen? The answer is no. There are no genetic tests that will say whether or not you have ADHD or not. And that's because actually people may have these genes or these variations in genes. They may have the genes, but it doesn't necessarily mean that they're going to develop ADHD. And I think that's a really important bit. So I would not advise going and wasting your money on Harley Street on these genetic tests.
Yeah, there's lots of them about, aren't there? So you talked about smoking and the use of other drugs in pregnancy. What about heavy use of alcohol in pregnancy? Somebody's asking about ADHD being a misdiagnosis of fetal alcohol syndrome.
Yeah, really interesting. So there are some data to show that, prenatal alcohol exposure does increase the risk of neurodevelopmental conditions, so both autism as well as ADHD. The data aren't quite as strong as they are for smoking, but they are there. And again, it's something that we will absolutely ask about. I think, misdiagnosis in terms of fetal alcohol syndrome compared to ADHD, I would hope that the misdiagnosis rates are really low because they are two really distinct conditions. And again, I think emphasizes the importance of having somebody adequately trained in doing that assessment. So whether it be the pediatrician at that time or a child and adolescent psychiatrist. But we can see them co-occurring as well. And I think that's a tricky one, is when we have fetal alcohol syndrome as well as ADHD. I don't know if, Joe, you had any.
Yeah, just on the point of pregnancy and treatment, previously we would say, we can't treat ADHD in pregnancy because there is not enough to say meds are safe in pregnancy. But of late, we've had so many cases where we've had to do that risk-benefit analysis, and we've had women who have stayed on treatment because if they were not treated, the risk of them going off and, using street drugs like cocaine or whatever would be much more harmful for the baby. So it's a harm minimization exercise where you would do that risk-benefit analysis in each individual case.
And do you get a misdiagnosis with personality disorder and ADHD?
Yeah, that's a definite yes. And in fact, if we are asked which are the most common misdiagnoses, one is personality disorder. In particular, I think I saw in the chat EUPD, emotionally unstable personality disorder, because mood instability, that emotional dysregulation as we describe it, is not a core ADHD feature, but you could say it's one of the commonest associated features. Something like 70 to 90% of people with ADHD, adults with ADHD, may have that frequent highs and lows in mood, getting angered easily or frustrated easily, and that coupled with impulse control problems. And if there is a bit of self-harm as well, then they instantly get that label EUPD or PD sometimes. And it can be a negative type diagnosis, which can stick with them. And, once they get that label, it may be hard to shift that really. So EUPD is certainly a common differential diagnosis. And I suppose the important thing to remember is it doesn't have to be one or the other. You can have patients who have both. So there can be overlap between personality difficulties and ADHD. The other often misdiagnosis can be bipolar. Again, the mood instability can be diagnosed as, bipolar, sometimes loose diagnosis of bipolar disorder. We've had patients who've been on meds like lithium for years, and it turns out that they never had bipolar disorder in the first place. It was the mood instability, and someone somewhere along the line, a clinician may have had that light bulb moment. Why is this patient just not getting better? And the same problems have continued, for years. And that could be a trigger point for a referral or a screening assessment, and then a referral for a fuller ADHD assessment.
Right, so I've got a great question about menopause. So do any evidence for, a link between symptoms getting worse and menopause?
Yeah, yes, absolutely, yes. Yeah, me and Joe can't wait. Yes. Yeah, there absolutely is. And there's actually evidence now to say that diagnosis rates are increasing during menopause too. And I think it's often very difficult because there's a lot of overlapping symptoms because of these executive dysfunction um, that we see in both menopause and ADHD. And unpicking those can sometimes be quite interesting and quite challenging. Yeah, particularly the sort of forgetfulness, poor organization, the inattentive aspects. And we know as well that there are some data to show that treating ADHD during that time can really help with that. Joe, I don't, do you want to add?
Yeah, fully agree with that. We're getting high numbers of patients getting referred in the menopausal age group. It's not that the problem is new; it's just that the impact of the problem is getting more in that sort of age group. And now the understanding is estrogen may have a protective effect, and as estrogen levels drop, I think it's affecting people harder. And the other thing we find a lot in clinic, patients saying my meds don't work as well as I'm coming on a period, premenstrually symptoms getting worse or meds not effective. So again, I think our understanding now is that premenstrually symptoms can be worse. Again, I do a couple of clinics for perinatal service, and postnatally we find a lot of worsening of they may have had neurodivergent traits, but the number of patients getting referred for ADHD or autism assessment in that perinatal period because they're much more challenged and the neurodiversity becomes much more impactful. So yeah, postnatally symptoms can be worse, and perimenopausally symptoms can be worse. So hormones and ADHD are a whole topic in itself.
And is there much research going on?
Hopefully there'll be more emerging evidence. So I think there's there was a UK Adult ADHD Network conference earlier this year, and there were Canadian psychiatrists presenting saying they use, say, for example, higher doses of medications in the lead up to a period, and so differential dosing. And there's some emerging evidence, which sort of resonates with clinical experience of patients reporting that.
Yeah, fascinating. Really, really interesting. There are a few questions about particular substances that people are using, but Lizzie is from the Benzo Research Project, I think, and she wants to know if there's any evidence of use of benzodiazepines in ADHD.
There are, so yes, not quite as high as alcohol and cannabis and cocaine and the stimulant type. Yes, there is evidence. A smaller amount, and I think again from clinical experience as well, I've often seen it. There's a co-occurring anxiety disorder as well, so I think being careful clinically to make sure that we've not just got ADHD, that if there are those co-occurring conditions as well, and making sure that they're adequately managed.
Brilliant. Okay, so we'll move on to Joe in a sec, but there's just about the menopause and gonadal steroids and ADHD. Vicky is asking about puberty.
So I often show a graph of estrogen and progesterone and describe the sort of puberty years of being an upward roller coaster of when estrogen and progesterone actually get to their highest. And being that roller coaster, it is ups and downs. And we do think so that the emerging research is suggesting that actually lower levels of estrogen lead to lower levels of dopamine, which increase the risk of ADHD symptoms worsening or being more impairing. And so again, going through those dips of puberty, absolutely. And then the evidence of premenstrual dysphoric disorder, PMDD, as well, increasing in rates during those pubertal years too, which again, there's some really preliminary research. We need a lot more looking at the link of PMDD and ADHD, which again, is really interesting. And there does seem to be a small correlation at the moment. But again, we need much more research looking into that.
Brilliant. Thank you very much. Okay, so let's move on. Thank you. Keep your questions coming. Clearly, these are the people to answer all your questions. So Joe Johnson, thank you very much for coming. He's a consultant psychiatrist. And Joe set up one of the first adult ADHD clinics in the Northwest way back in 2008. And he may tell us about the the difference in the referrals that he's getting now compared to then. I was very shocked about that. So he's been heading up that service ever since. He's been working on adult ADHD for a long time. He's the Northwest lead for the UK Adult ADHD Network, and he also, I don't know how his time, but he works with a charity called the ADHD Foundation. So very warm welcome to Street Drugs Discussions, Joe.
Thanks, Joe, for the kind introduction and for inviting me to be part of the panel. And wonderful talks from Chris and Anneka. So I'm going to focus more on the overlap between ADHD and substance use disorder, and particularly we'll focus on a consensus statement, which I was part of. So I think we've covered this, Anneka just covered in her talk, but just to kind of emphasize that point, the overlap between these two conditions is huge. If you look at the prevalence of comorbid ADHD in adults with, substance use disorder, or those adults who are seeking treatment for their substance use problem, you look at 100, about 25%, staggering numbers, a quarter of those people seeking help with their substance use problem may have ADHD. So I think there were some comments I saw in the chat. What do we do? Maybe that's a point of discussion. Those working in substance use services, what can we do to improve things? Do we screen for ADHD? And if we screen, and if they screen positive, what next? So I suppose that's a topic to be discussed. How do we take things forward? Just to be aware that it's a hugely overlapping condition. And if you look at prevalence of ADHD, and I could just presented in general population, it's 2 to 3%. In this group, you can see it's almost like a tenfold increase in comparison to the general population. When you look at the benefits of treating ADHD, we can certainly say ADHD is one of the most treatable mental health conditions. We compare ADHD medications in ADHD versus antidepressants in depression. It's almost like there's no comparison. Significantly better results in terms of efficacy, benefits of treatment. And what are the areas where you get those benefits? We see in terms of percentages, improvement in driving, almost 100%, obesity, improvement in those eating problems, which may be linked to the impulse control or the dopamine deficiency. You can see a number of areas, self-esteem, social functioning, academic functioning, not far behind in that list, drug and addictive sort of behaviors, improvements, which are certainly worth treating because you could get those benefits in those sort of patients, better outcomes. One of the myths around ADHD is that, by giving medications like stimulants, you're increasing the risk of them getting hooked on, addicted, concerns around addiction. Sometimes ADHD can be seen as a drug company invention to sell their medications. And what does actually research say? Is there a concern, or is it just a myth? And the reality is it very different? And meta-analysis have found that stimulants do not increase the risk of alcohol, cocaine, or cannabis abuse or dependence. And if anything, it's the opposite. Treating ADHD would improve outcomes in the drug misuse problem as well. And how do we know this? Looking at these big studies, Swedish and Danish registry studies are well known because of their huge sample sizes. So this publication, Swedish registry study, 38,000 patients studied, and they found that there was a 31% reduction in substance misuse. The longer the duration of treatment, the lower the rate of that substance use. So it's certainly reassuring for us working in these areas, both in ADHD and in substance use services. It's more a myth that treating ADHD will worsen addiction problems. It's more than likely to improve the addiction issues. The outcome in secondary substance misuse problem would also get better. Increasingly, we see ADHD as a primary disorder. And what do we mean by that? A primary disorder left untreated can increase the risk of secondary problems. So you could say anxiety, depression. These are secondary problems that can, high risk of patients with ADHD, if they're left untreated, would develop anxiety or depression or personality difficulties. And certainly you could confidently put substance misuse as a high risk of a secondary substance misuse problem if you left ADHD untreated. The analogy is with blood pressure problem. High blood pressure can be a primary problem if you don't treat that, and the patient goes on to develop angina or a stroke or heart attack, something much more serious, there's no point giving anti-angina tablet without treating the blood pressure. So that primary disorder and secondary disorder helps us understand where ADHD and substance misuse could fit in. And we've been hearing why patients with ADHD are at higher risk of having those substance misuse problems. Is it they're self-medicating? Is it those dopamine deficiency? Are they trying to fix that problem? Or is it the impulse control problem, which is common to both groups? So those are, just for me to set the scene before I talk to you about this consensus statement, which I was part of. This was a publication in the World Journal of Psychiatry in 2023. And there was a group of clinicians from different areas. And I was one of the psychiatrists who was part of the panel. So there were psychiatrists, psychologists, there were clinicians from adult mental health, children's mental health, people who worked in substance use disorders. There were service user representatives, so right range of clinicians, researchers, etc., got together to see could there be some sort of consensus on what should be accepted in terms of both diagnosis and treatment. And I'll take you through this paper, which is published quite a lengthy paper. There's quite a lot to read. So I'm going to summarize this consensus statement over these next few slides. So as I said, there was this group of experts that all got together, and it was a whole day exercise, and then it carried on for almost a year, a lot of doing and throwing discussions online, etc. So the group that got together, they were divided into 3 smaller groups. One group was involved in the discussions around, substance misuse problems. What are the reasons why people abuse drugs? Second group looked at identification, assessment, and treatment of SUD or substance use disorder in people with ADHD. And the third group was the other way around, identification, assessment, and treatment of ADHD in patients presenting with substance use disorder. And the whole group got together to see could they come up with some sort of consensus on both the diagnostic part and the treatment part. And this then followed with a lot of meetings, virtual meetings, and a medical writer was involved in supporting. And this draft was circulated several times before, the disagreements were kind of ironed out, and there was some sort of consensus, which was eventually submitted, and the publication was last year. So we'll divide this consensus statement into 2 halves, the identification part, the assessment part, and then the treatment part. And what did they say? What did this paper say? I suppose the first and foremost, important to know, these 2 conditions can hugely overlap. There can be that diagnostic overshadowing. For clinicians, it can be really confusing to know which is what. I suppose one thing we know is ADHD is not a condition suddenly you develop, it's almost certainly something you probably had, dating back to your younger years. As Anneka presented, one of the core criteria for diagnosing somebody with ADHD is symptoms dating back to age 12 or earlier, as per the DSM criteria. So if you have a patient presenting with substance misuse problems, and if you're assessing them for ADHD, you really need to be able to confidently say the ADHD problem almost sort of goes right back. It ideally should predate the substance use. But where it can be challenging is in clinical practice. Sometimes you hear patients say, I started using or smoking cannabis when I was 12, that young, so it can be really challenging. Often we hear started off with cannabis, progressed to using various other drugs. One thing we know that there can be this link. So the chronology of symptoms would be very important, which are overlapping. I suppose impulse control, as we hear, patients with substance use problems are often very impulsive. They are easily led. They just, can keep doing the same thing without thinking it through, the impact, the consequences. And for ADHD, impulsivity is a core feature. So that can be like a real overlapping feature. Now, when you assess somebody for ADHD, what is the timing? When can you assess? Can you assess somebody when someone is intoxicated? Not really. You can't assess somebody when they're intoxicated. You can't really assess when they are withdrawing. Probably that is not also something we should do. ADHD assessment should not be conducted at a stage of withdrawal. When would be an optimal time to assess? Ideally, following a period of sustained abstinence or, had the detox, or they're stable, ideally. But I suppose the reality is, if they're a chaotic substance misuse sort of, is an ongoing problem, that stability can be relative. You may have to say you're prepared to meet the person halfway. Gone are the days where you can say, deal with your substance misuse first, then we look at ADHD. And that may never happen because that substance misuse may be an ongoing problem. So you may want to really work with them, try and do that assessment at a period of relative stability, always bearing in mind, the risk factors involved. The last point here, collateral information. As we know, one of the core aspects of an ADHD assessment is getting useful collateral history. And it may be challenging for a lot of these patients. They may have distanced themselves from all their family and friends because of the substance use, the chaotic lifestyle. Maybe they have engaged in a lot of criminal activities to fund their drug habit. And sometimes getting that collateral information may prove difficult. But absence of collateral informant, that shouldn't be a reason to say, well, we can't assess you for ADHD. Now, this slide looks at the overlapping symptoms between substance use disorder and ADHD. If you look at it, a lot of tics, pretty much all of those listed there. It can be overlapping. Restlessness can be an overlapping feature between the two. Impulsivity can be overlapping, concentration issues, low tolerance to frustration, risk-taking behavior, sleep problems. You can see it can be really challenging to unpick, when these conditions overlap. One thing for sure, one thing we know for definite, ADHD is a highly comorbid condition. We hardly ever see just ADHD. Almost always we find overlap with mental health conditions, overlap with other neurodevelopmental conditions like dyslexia, dyspraxia, autism, etc. And there can be huge overlap with alcohol and substance misuse problems as well. So bearing in mind ADHD is highly comorbid, and what we say is comorbidity is the norm, not the exception. Now, looking at what did the consensus statement say when it came to the treatment, both pharmacological and the psychosocial interventions, active users of substances should not be offered ADHD medication. It should be offered ADHD medication subject to risk assessment. So you can treat even if somebody had an active substance misuse problem. There are a few caveats, there are a few considerations. Absence of substance use is not necessary for people to benefit from ADHD medication. As I was saying, you may have to work with these patients and meet them halfway. If they're prepared to work on their substance misuse, cut down their drug misuse, that would be enough incentive to work with them. And, we've had many, many success stories where patients have completely managed to get off their drug misuse problem, and now they're on prescribed medication. So that working together, maybe joint working between an ADHD team and a substance use team, or they may be also open to mental health teams. So joint working becomes really important. In terms of choice of medications, longer acting stimulants are preferred. They're seen as less abusable in comparison to the shorter acting stimulants. So with the shorter acting, there is the peak and trough, whereas longer acting is a much more sustained sort of a benefit, and the highs they can get out of a longer acting stimulant is much lower in comparison to a shorter acting stimulant. Non-stimulants like atomoxetine can be effective for some patients, but you'd stick with NICE guidance. Generally, NICE would say you would want to consider a stimulant generally preferentially over a non-stimulant. But if somebody has an ongoing active substance misuse problem, maybe you may want to consider a non-stimulant like atomoxetine. But what if they haven't responded to atomoxetine? You may have to go to a trial of stimulant, but there you would choose a longer acting stimulant over a short acting stimulant. There are cases where you may have to consider short acting stimulant, but you have to be really careful of the potential for abuse and diversion. It may have to be supervised administration, etc. I did work in a prison for a number of years, and we used to have a lot of our patients or inmates who had supervised administration of medication. The last point, despite lower risk of misuse or diversion for long-acting stimulant, as clinicians, people have to be really vigilant on things like if patients are repeatedly coming back saying, I lost my prescription, or they're ordering prescriptions in too early, or insisting that they wanted the shorter acting version. So there are times you have to be a bit careful, really. is there an abuse happening here? This next slide, this is a graph looking at peak plasma levels when you take stimulants. So looking at not just the prescription type stimulants, but what if somebody injected amphetamine? So on the x-axis, you can see is, how soon does the stimulant get into your body? The first half an hour, 0 to 0.5. What are these drugs which gets you that peak plasma level quite quickly? You can see IV amphetamine, the one marked in green, or IV or snorting cocaine, one in red, can get a peak plasma level, nasal cocaine. So those are ones where you can get more that real fast action within the first half an hour. But if you look at stimulant medications here, there's only reference to methylphenidate. If you looked at immediate release methylphenidate, which is the one marked in blue, that is much slower in comparison to the other ones we just talked about. You get the peak plasma level, so maybe closer to the at the end of 1 hour. That's where you get that peak level. With the slower release methylphenidate is much later. The point that we're making is, if you're taking it as oral immediate release or slow release methylphenidate, you're unlikely to get that kick, the high. Now, the consensus statement looked at what are the risks that clinicians have to be aware of if somebody who is treated for ADHD is also using recreational drugs or drinking alcohol in excess. So they put them in different groups. At the bottom of that slide, you can see moderate risk was 1+, considerable risk was 2+, and high risk was 3+. So what are those risks involved? So intoxication dependence with alcohol, cannabis, can increase paranoia. A lot of patients say, that calms their nerves. Anxiety is treated with cannabis. Cardiac, something to be aware of with cocaine. Cocaine can be cardiotoxic, and meds we use stimulants, and methylphenidate can also have an impact on the heart. So if you have a patient where you're prescribing methylphenidate and then they're taking cocaine, or it's something you have to be mindful of, really. There is a cardiac risk. Other ones listed, you can see LSD, ketamine. I won't read each of them in the interest of time, so that we'll have more time for discussion. But some where you have to be cautious when you have a patient who is on meds and if they are likely to abuse other drugs. But the main one I wanted to touch on was cocaine, that cardiotoxicity, but also risk of seizures, for example, with some listed there if there is a history. So you want to have a section in your assessments, a medical history as well. Now, the psychosocial interventions, the psychological treatments, as we know, it's not just all about taking medication. So you have a range of treatment, the biological, psychological, and social treatments when it comes to working with patients with a drug misuse problem, setting realistic, achievable goals with that SMART framework. Motivational interview plays a big part, helping your patient to go through those sort of phases. Psychoeducation, so very important, working with patients to help them educate themselves, and also those sort of behavioral analysis, if they've been so heavily reliant on taking drugs, that was their way of life, all their whole life revolved around that, all their peers, their networks, they're all drug taking. And, it's almost like a new chapter in their life, rebuilding their life. What do they replace the drug taking with? How can they become a useful, valuable member of society? What can they do, which may give them that almost dopamine fix? It could be exercise or other things, so psychoeducation certainly has a key role to play. So I'll draw this session to a close, discussing the conclusions from this consensus paper. Again, we can't emphasize enough that diagnostic overshadowing risk and the risk of ADHD getting missed, high risk of patients with ADHD getting missed. And if you screen that patient population, say substance use cohort, you will find high numbers. So there are certain patient population where ADHD is significantly higher than the general population. So one is substance use, certainly with a topic we're discussing. Another one would be forensic population, patients open to criminal justice team, probation service, a youth offending team, or criminal justice liaison team, prisons, etc. Another group would be patients who already are open to mental health services. They're high risk of having ADHD as an add-on, as a hidden diagnosis, or we were discussing EUPD before. It may be that they've been wrongly diagnosed as EUPD or bipolar. It may have been ADHD. Now, coming back to substance use discussion, assessment should not be conducted at a stage of intoxication or during active withdrawal. Optimal time of assessment would be following a sustained period of abstinence or after a period of stabilization. But you have to be realistic in that assessment time, individual to that patient. Abstinence of substance is not necessary for treatment with ADHD medications. Prioritize long-acting preparations over short-acting, and there may be a role for the non-stimulant type medications like atomoxetine. Treatment effect is likely to be higher when you combine pharmacological treatment with the psychosocial interventions. I'll stop there, Joe, and back to you for questions and discussion.
Thank you, Joe. Fantastic. That's a lot packed into that presentation. I have a really good question here about autism and a question about complex trauma.
Yeah, very, very good question. Huge overlap with autism and ADHD. To start with, back in the day, the thinking was these two were mutually exclusive. As in, if you had autism, you can't have ADHD. If you had ADHD, you can't have autism. And that the thinking has almost been turned on its head. Now the understanding is if you have one, you're much more likely to have other. Research say that those patients who are diagnosed to have ADHD, maybe a fifth of them may have overlapping autism or autism spectrum condition. If you look at it the other way around, patients who are diagnosed to have autism as the primary diagnosis, something like 40%, 30 to 40% may have overlapping ADHD features. So, the overlap is so much that we start wondering, should we be assessing anyone referred, should we be screening anyone referred for an ADHD assessment for autism and vice versa? I think there is a real argument for doing that. Now, coming to trauma, having ADHD, would that put you at a higher risk of having a traumatic event? It's not terribly surprising. It does make some sense, really, isn't it? If you're impulsive, you're acting without thinking, and you're at that dopamine seeker, you could put yourself in those situations which put you at higher risk of a traumatic event. But if you've had trauma and PTSD or complex PTSD, and something we have to do, in clinical practice, trying to establish, is it better explained by PTSD or CPTSD, or is it more ADHD? And is it a bit of both? I suppose from a treatment point of view for ADHD, the mainstay of treatment can be pharmacological treatment, although psychosocial interventions can have a part. But for trauma, the mainstay of treatment is more psychological treatments like EMDR and other therapy, trauma-focused therapy, etc., with perhaps a lesser role for medications.
Also, somebody asking about mindfulness-based practices.
Yeah, there is less research on the psychosocial interventions in the world of ADHD, isn't it? So we have more evidence, more literature on the more medical treatments, but that's not to say psychosocial interventions don't have a role. So tailored CBT tends to work really well, than sort of one size fits all type of standard CBT, which is offered through primary care psychological therapy services. Now, coming to mindfulness, there is evidence to say mindfulness can help. But in terms of the research and the literature evidence, again, this is where I may call on you, Anneka and Chris, whether there is enough. Probably I'm not aware of, so too many research, but, we've had so many patients who say, once my ADHD is treated, I was much more able to do, the mindfulness practice or my yoga or meditation. So, the chances of engaging in those sort of psychosocial interventions are improved often by treating that mental restlessness, that inability to sit still if it's treated. Otherwise, you can imagine if someone just can't sit for 2 minutes, they're so restless, they're so impulsive, and they're so blurting out, etc., it becomes impossible. They've had so many patients who've been referred for all sorts of psychological interventions, including mindfulness and CBT and various other therapies, but just not being able to engage in therapy simply because their mind is not calm.
Yeah, I think I'd agree totally, Joe, with that. So at the moment, there isn't, the evidence says that mindfulness is not actually effective in treating ADHD. We've just done a review. It's not published yet, but that's, early results. What I will say, though, is that and this is where our work tries to move it forward, is currently clinical trials, we look at the average So we take the average of patients and we say, on average, this treatment doesn't work. But actually, what we think is that if we use the individual patient data level, we might be able to find those patients who may actually find mindfulness helpful, who may actually be the ones that respond to clonidine, who may be the ones that respond to psychological therapies. And, we're still doing that work. And the second bit, Joe, I totally agree and have seen in clinical practice is that actually treating the ADHD first then allows people to engage better in these psychological therapies, mindfulness, which can then be really beneficial for maintaining those effects and the sort of practical approaches.
Brilliant. That's great. Thank you very much. So opiate substitution therapy along with ADHD meds.
Good one. We often get challenged with this. If somebody is on methadone, what do you do?
Yeah.
For example, you definitely want to take a good cardiac history. Is there any family history of heart disease? Is there anyone in the family under the age of 40, family member dying young? Or is there a family history of ischemic heart disease, any structural sort of heart problems like cardiomyopathy, etc.? But if there is that history of taking, methadone, high dose methadone, personally, I would want an ECG, a baseline ECG, just to be on the safe side, just to make sure that, physically they're okay. And if there's any other cardiac risks involved, then I would really want a cardiology opinion as well before embarking on treatment. And when I do, I'd probably start on lower doses and titrate slowly and cautiously.
Totally agree. Yeah.
Fantastic. Thank you very much. Well, Alison, I think we should hear from you now. So Alison MacKinnon was diagnosed with ADHD nearly 4 years ago when she was 26. And when she came back into education to study psychology, and she wants to she plans to channel her passion for drugs and her disdain for drug policy. I like that, Alison, into becoming a neuropharmacologist. So very warm welcome to Street Drugs Discussions, and it's a real pleasure to hear from you about your own experiences.
Thank you, Joan. Thank you so much for having me. Kind of to reference back, I know there's been a lot of talk about what we can do to deconstruct stigma around both ADHD and substance use. Well, things like this are important in giving people a platform, specifically people in those communities, a platform is one of the most important ways we can do that. That and lobbying your MPs if you want to get real saucy with it. But, we don't all have time for that kind of stuff. So, as Jo mentioned, I was diagnosed with ADHD as an adult when I went back into education. And I'd had, at that point, a few experiences with drugs. And I'm obviously going to start this by caveating it with the explanation that this is anecdotal evidence, that my experience with drugs will be different from other people's experience with drugs and other people with ADHD's experience with drugs. There's different motivations behind why people use drugs. My thing over the years has mainly been for the mood changing effects of drugs, I think, was what I was always trying to gauge with this. So I have a few anecdotal stories around this. Like many people who are musicians and doing the festival scene, I was introduced to weed relatively young. I guess I was like 18, 19, just here and there at parties kind of thing. And it wasn't until my first degree that I started smoking regularly as a way of focusing my attention. And this is when my tobacco use started as well, because it was in combination. I don't really smoke cigarettes outside of that. Weed is something that, alongside focus, like helping me mediate my focus, like other people said, it helps me relax. And so I have now got a prescription for that and got that sorted out. It also helps with my chronic pain symptoms. So a lot of other people with ADHD will have similar kind of experiences with chronic pain or IBS. So it helps with those kind of symptoms for me. And a few of my friends kind of have a similar experience with ADHD in that regard. Meanwhile, on the opposite end of the scale, I have like one anecdotal story about a time at a house party where I took cocaine. And it was weird because obviously people really tout it as something like, oh, it's going to make you feel good. And then throughout the night, I wanted to keep up with the cool kids. So I was like, oh, go on, then I'll try it. Maybe I'll feel different this time. But what I found was over the course of the entire night was everybody else was just having a great time. And I was just sat there like really calm, which is the opposite end of the scale I'm normally at. Just sat there like, oh, I wish I just had a joint so I'd feel relaxed now rather than just feeling like I've drunk an energy drink, because that would have been about £100 cheaper. And yeah, I guess like a few times after that, I did try it again, thinking maybe that was just bad cocaine. But yeah, I'm glad for that as well, because had I been trying to like feel normal, that would have been a very slippery slope for me. But again, my motivations for drugs has normally come from a place of how do I feel different or better or change my consciousness, I guess. That's something that we say goodbye to, because I'm not out here risking a heart attack for something that doesn't make me feel any different. And then later in life, so in more recent years, after a trip to Amsterdam, I guess I got more involved in psychedelic, not just having taken psychedelic drugs, but research. And that's what's led me down the path of wanting to do things and like wanting to destigmatize not just drug use, but also the people that it impacts, because it often falls under people that are already stigmatized. But yeah, I mean, my experience with psychedelics really allowed me to kind of step into metacognition, so thinking about how I thought. And because I had so many well-rooted thoughts about, oh, my brain's a bad place to be, and it's a scary place. I have too many thoughts. I don't have a mind's eye, so I'm constantly internal narrating everything, as many people with ADHD do experience. And I spent the first few times I tried psychedelics going, where's my like visual experience? And then suddenly my brain just flipped and went, hey, your brain works with words, and that's really nice and beautiful, and it's just different, you know. And so that really helped me step into therapy in a new light and apply that kind of thinking about like, my head's a bad place if I want it to be a bad place, and it's a good place if I want it to be a good place, kind of thing. And I think potentially that's something I would have come to with years of meditation and stuff like this. But like that immediate being able to step outside of the thoughts and go, oh, I'm not in this all the time, I can observe it, really helped me in my journey of self-compassion now. Which is needed because I'm on my final year of my bachelor's for the second time and about to go down the master's path and stuff. So in summary, it is important we understand why people are doing drugs more than anything, so we can find different ways of treating it. You know, someone mentioned about telling the difference between trauma and ADHD responses. I once had a therapist I did say that to, and the therapist was like, as far as we need to treat you, it doesn't matter. Like, what matters is the impact of those symptoms. And that's kind of how I feel about attitudes to drugs as well. I've been very lucky that I've been treated by private psychiatrists, and they've been person focused of like, well, do you feel bad about your weed use? Is this it like negatively impacting your life? And given the autonomy back to me, which is another way we can empower patients, because ultimately we need to build up the support systems without just leaving people to go, oh, well, you're taking drugs, too bad, we can't help you, you know. Yeah, I think that's everything I had to say. Sorry, I didn't present slides because I thought it would be silly to just put a big slide up saying, I'm Alison and I've taken drugs. So, but yeah, I mean, I'm happy to answer any more personal questions one-to-one if people don't feel comfortable talking about, because I appreciate mine is more experiential. But yeah, I guess keep doing the good work, guys.
I mean, thank you so much, Alison. It's so brilliant of you to have come today. And it's just fantastic. Yeah, so pleased. Andy's saying he's so pleased that you presented here. Actually, everybody, there's loads of very positive comments in the chat. I think this has been absolutely fantastic. But Alison, thank you very much and for really opening up to us.
Thank you for having me.
Well, it's great. It's just great to hear from somebody with lived experience. You know, it's so important. And I actually, John's been asking a lot about how do we tackle the stigma? How do we tackle the stigma about people who use drugs? Drug science, you know, street drugs. We're working on this all the time. It is hard. I don't know if I live in a bit of an echo chamber and I think it's getting better. I'm not sure it really is. And then people with ADHD as well, it's really hard. But Alison, I think people like you, it is really down to everybody. And I love that you suggest lobbying your MP, because actually the laws are not going to change unless, Parliament understands the evidence for why we need to change our drug laws and change our attitudes to mental health and discussions in substance use disorder. And so I absolutely think you should lobby your MP. You should write to your MP. There are many MPs in Westminster who want to see things changed. And the more we can do, to influence this, the better. And the more evidence that we can present, the better. I'm really interested in you saying you've no mind's eye. A friend of mine here has no mind's eye, and I read a study about psilocybin and somebody who then developed a mind's eye. It was extraordinary, I thought. I'm interested in your experience with psychedelics.
So I did. I got a bit risky one time, and the walls did start to do that thing that seeing eye posters do. But yeah, it was I think I'm because often when I'm in a social setting, other people are reactive to drugs a lot faster than I am. And I even have this with weed edibles. It doesn't really work on me. I think everyone obviously just processes things differently. When I took a lot, things did start to move, but on lower kind of more social doses, I guess, or I don't know, it's hard to dose drugs when they're not regulated. I would see things when I closed my eyes. One time I put on Dark Side of the Moon and just closed my eyes and remembered what it was like to be 14 again and learning to play guitar. And then I was my brain was showing me really weird stuff. I was like, oh, a swimming pool that's empty. And I was like, but cool, because my brain's actually showing it to me. So for me, it wasn't a scary experience. But I could imagine that might be if you want to shut your eyes because you're like, oh God, this is overwhelming. And then suddenly in your head, there's all these colors too. But yeah, that goes the next day. And it's weird because I can obviously describe things as if I have an image in my brain, but I can never actually bring that image up in my head.
Really interesting. Somebody's asking about high THC cannabis and that, with more CBD in it. Is there a difference?
So I guess with prescriptions, they start the CBD higher and the THC low if you're approaching from a mental health perspective. So I was prescribed for depression. And so that they're obviously trying to reduce the risk of paranoid symptoms and stuff. But obviously I did explain to them I'd been a street drug user for the better part of the 5 or 6 years at that point, but obviously there's protocols we need to follow and stuff like this. Obviously a lot of stuff on the street tends to be much higher in THC and lower in CBD, which is where bad drug policy begins to take root in people using drugs, because people are much more likely to get addicted and habitually use weed when the THC is much higher, and you're more likely to get other side effects like nausea. I do get there's a cyclical vomiting syndrome that's specific to cannabis users, that I feel those symptoms are triggered by particularly high strains. So for example, when I'm in places like the Netherlands where it's regulated and it's lower doses, I wasn't getting as much the psychotropic effect, but I wasn't getting as much the lethargy and the gastro symptoms, I guess.
Fantastic. Wow. Thank you everybody for coming. This has just been absolutely extraordinary. I just have there's one thing I wanted to ask. You touched on this, Alison, about the physical symptoms that go along with ADHD. Can our experts comment briefly on that? I thought that's really interesting, because of course we all have lots of physical symptoms that go along with having disorders. Anneka.
Yeah, so there are some data actually very new this year that do show that there are increased rates of things like fibromyalgia, but also connectivity disorders as well. We don't know why. We also know things like epilepsy actually is often higher with people with ADHD, but again, we don't know why. So I think still a lot of work to be done in that area.
Really
Yeah,
interesting.
definitely. Yeah, I've seen many cases of fibromyalgia and hypermobility syndrome in our clinic. So maybe there are some shared genes with maybe in time we may know more on the sort of overlap with some of these physical health conditions.
So we're learning a lot, aren't we? Gosh, wow, what a webinar. It's been absolutely fantastic. I have learned loads. The time has absolutely whizzed by. I can't believe it. Have you speakers got a take-home message for us? Anything you'd like to finish on or not?
I could probably go first on this. I've seen one or two questions about what can we do? Now we hear that there is huge overlap. Is there something we can do? I suppose the practical challenge is, attend a webinar like this, and that makes you more aware. Awareness has certainly gone up about neurodiversity, ADHD, autism, etc. And, imagine you have that, some sort of first patients referred with significant substance misuse problems where clinicians working in substance use team who may have gone for an ADHD training course or something where they then start seeing so much ADHD in their caseload. So I suppose awareness is good and screening would be good. So I suppose that's a real key point. There's high likelihood of ADHD in that cohort of patients. So screening would be good. And I would say encourage clinicians working in substance use teams to skill themselves up to, maybe take them up to the being able to be diagnosticians. So going on courses, shadowing ADHD appointments, linking up with your local ADHD service. That the practical challenge is most of the ADHD services have got such long waiting lists. Even if you have identified someone as potentially likely to have ADHD, you refer them on, they can't get on to be seen in a timely manner. So I suppose being those linked practitioners and skilling yourself up as a clinician to work with the ADHD team so that you can work with that patient and hopefully, we can all collectively work on these sort of very long waiting lists, because ADHD is a common mental health condition and a very small team won't be able to meet the demand of all those patients out there. So joint working certainly is a take-home message.
Brilliant. Thank you so much, Joe.
Yeah, I echo what Joe says actually, and I've answered a few questions in the Q&A and felt frustration from people with active substance use issues or working with clients with substance use issues, and actually being told that you need to be abstinent before you'll be seen. And again, this is something that we need to move away from in the NHS. And I think, as Joe says, the best way to do that is that sort of joined up care. At the moment, ADHD services sit in their little satellite, usually separate from mental health services. So joining those up, but yeah, I think more resource into ADHD services. I heard a patient the other week who said it was a 13-year waiting list for an adult ADHD assessment in their area. I know. In Oxford, we've closed the waiting list, so there's nobody can be referred. So it's absolutely dire. So I agree with Alison and yourself, Joe, with rallying round for MPs, because ultimately we need more funding to be able to better resource so that these essential services are actually serving the needs of people. Because even doing screening in addiction services, and again, in the whole of Thames Valley where I work, we've got one addiction consultant. So it's unbelievable. So again, more resource into these addiction services to be able to support people out there that are really, really struggling.
Yeah, we needed a lot more funding, a lot more support, focus. Thank you very much, everybody. So many thanks going into the chat. And actually, I have a big thank you to Hannah from Drug Science, who's been behind the scenes doing all the hard work for this. So thank you very much indeed, Hannah. That's been fantastic. We could not do this without you. And speakers, wow, thank you so much. Absolutely brilliant.
Thank you for having us. Great to see you.
Yeah, thank you so much.
Thanks.